pros in the field is really an honor and a pleasure. So thank you so much. This talk really is more of a one-man show. I'm trying to get a new career in stand-up. It turns out my humor is very niche. So unless you do like antibiotics, people don't get it. So I'm not sure this is going to take off career-wise, but really look at this more as entertainment than education. And it really isn't entertainment more important anyway. So what we're going to do today is we're going to ask the following question. Is it reasonable to use oral antimicrobial therapy for 3 diseases that historically the medical community has said absolutely not? Don't even think about it. Completely unacceptable. Osteobacteremia and endocarditis. Our question is it reasonable to consider oral therapy for these diseases? Now, I'm going to show you a bunch of data, but before we get to the data, I'd like to spend around 10 minutes discussing a philosophical framework for how to think through interpreting the data. So there are both pro and con arguments to answer this question. I am not known for my subtlety. I have a subtlety index of 0. Like if you drew my blood and sent it to the lab for subtlety assay, it would be below the limit of detection. So you'll probably be able to tell which side of the argument I'm on as we go through the pro and con components. There are 3 principal components to the pro argument that it is reasonable to consider oral therapy for these diseases. First, in contrast to older historical antibiotics, and we'll show some of this data, modern oral antibiotics absolutely achieve adequate levels in blood and bone to inhibit microbial growth. They're above the target MIC of those bacteria. Now, another way to think about this is the bacteria don't actually know the route of administration you entered into your EMR that the nurse should administer the antibiotics to the patient. It's not like there's like bacteria in bone somewhere going, well, normally if there was this much antibiotic around, I'd stop growing, but you chose to give it orally, so I simply refuse to stop growing. Those little bugs, they're smart, but they're not that smart. Second, we know for sure from numerous prospective studies, including randomized controlled trials, that giving the antibiotics intravenously is intrinsically less safe. We tend to underestimate the rate of harm from leaving plastic tubing in people's bodies for weeks on end. And it turns out hominids did not evolve with large plastic tubes in our central veins. So that in prospective studies, the rate of injury of fairly serious natures, DVTs, line infections, fracture of the line migration, which might need surgery or IR intervention to retrieve, bleeding, central venous stenosis. The rate of these things is in excess of 10%, and in some studies, upwards of 25, 30, 40%, depending on which prospective study you look at. We really underestimate the harm we cause with these IVs. And finally, third, there are now extensive randomized controlled trial data, which I'll show you, demonstrating that oral therapy actually is as effective, if not better, than IV for all 3 of these diseases. Now, when you consider these 3 components in aggregate, it feels like a pretty potent pro argument that oral therapy is reasonable. But they are counterbalanced by 2 principal con arguments. And believe me, I've given this talk probably 80 times now, and plus the local people I argue with, people yell at me all the time about this. It's almost my full-time occupation to be yelled at about this. This is what they yell back at me. Okay, first, any data you show me suggesting that oral therapy may work for these infections has imperfections in it and may not reliably extrapolate to all organisms at all body sites of infections in all patients in all countries in all planets in our solar system, in all solar systems in all galaxies in all the entire universe. And second, if you cannot show me perfect data with no flaws that extrapolate to all organisms at all body sites of infections in all patients in all countries in all planets in the solar system in all solar systems in all galaxies in the universe, then we have to keep doing what we've always done. Those are the principal con arguments. to why you shouldn't use oral therapy for these three diseases. And here's my problem with those con arguments based on historical practice. Continuing, I'm going to tell you the story of Dr. Benjamin Rush. Now, I don't tell you the story to disrespect Dr. Rush, to make fun of Dr. Rush. The point of this story is really that no matter how brilliant you may be, and no matter how famous or eminent or influential you may always be wrong. That's really the point of this story, okay? So let's talk about Dr. Rush. This was a major figure in the history of this country, beyond being a physician. He was a signer of the Declaration of Independence. He was the Surgeon General of the Continental Army, reporting directly to Washington. Not beyond being a physician, not only was he, a brilliant practitioner of medicine, but he was actually a science thinker. He believed in studying nature to try to improve people's lives. So he was a leader of what was the American scientific enlightenment in the colonial and post-colonial era, and was certainly the most famous physician of his era, frankly, of the 100 years that followed. There's a reason there's a medical school named after this guy. Now, he also was a believer in bloodletting and probably killed some people during a malaria outbreak in the DC area. But more importantly, for our purposes today, he was the inventor of something called Rush's Thunderbolts. Now, it's very important that you understand that I'm not actually making this up, because you're going to think to yourself as I'm telling you this story, there's no way this is real. You've completely made this up. But you could, while I'm giving this lecture, you could stave off comahood by Googling Rush's Thunderbolts on your smartphone, and you'll see that I'm not making this up. What were Rush's Thunderbolts? Rush's Thunderbolts were a purgative cure-all for whatever ailed you that he patented and made a ton of money selling. And so they were purgative. So the way they worked is they induced voluminous diarrhea to expunge the evil humors from your body. And they were used for anything that might ail you. So if you had a fever, you needed a Rush's Thunderbolt. If you had abdominal pain, well, you need a Rush's Thunderbolt. If you fell and broke your arm, well, you need a Rush's Thunderbolt. They were used for everything. And this is, again, also true. They were so popular at the time. These were the principal medications Lewis and Clark purchased. They purchased several hundred doses of them to take with them on their journey out west and back. And in their journal, they actually frequently documented administering Rush's Thunderbolts to their colleagues for various ailments, thereby successfully inducing voluminous diarrhea. What were the ingredients of Rush's Thunderbolts? What was in there? Well, there were two principal ingredients. First was an extract of the jalap plant, which was the thing that induced the voluminous diarrhea. And the second was mercury. And here's where the story becomes really sad. Doctors in the United States continued to actively poison people, overtly harming them with Rush's Thunderbolts for more than 150 years because Dr. Rush told them to. This is a photo of a pharmacy compounding manual published in 1946. This is in the penicillin era, people, and they were still mixing jalap extract with mercury to poison people because a century and a half earlier, Dr. Rush told them to. Historical practice that's based on no data and is nonsensical does not require perfect data to overturn. Any reasonable data suffices to overturn nonsensical historical practice based on no data. Evidence-based medicine is preferred to eminence-based medicine, or as my mentor taught me, he was chair of medicine when I was a student and resident, data beat no data, and better data beat worse data. Or if you want to quote from another luminary of medicine, Osler is said to have said, 50% of everything I'm teaching you is wrong. The only problem is I don't know which 50%. Osler understood he didn't have all the answers, and he wanted his students to go out into the world and evolved our practice as new things were learned. And I think he would be sad 150, 200 years after he said this to know that we still aren't very good at it. So I'm going to show you a bunch of data, like a bunch of randomized controlled trials. And if after I show you those data, you say to me, well, those data are flawed, then I'm going to have to presume you're aware of some contrary data that are not flawed. Because if you're not, there's a word for this. And that word is chutzpah. It takes some serious chutzpah to criticize 22 concordant randomized controlled trials when you have 0 to support the opposing position. And with that as an introduction, let us begin to discuss the 3 diseases in question. We will begin with an audience quiz. Now, you don't have to shout this out. You could just sort of think in your mind what the answer is. What is the oldest known case of osteomyelitis? How far back in time must we go to find the oldest case of osteomyelitis? People often will say things like, well, there's probably some mummies, right? You probably got some Egyptian mummies. They got some Pott's disease. You got some osteo. I've had people say to me, Neanderthal bones maybe got some osteo in them. I even had someone once suggest a woolly mammoth bone, fossil, whatever. But you have to go back a smidge further in time to this fellow right here. This is the oldest known case of osteomyelitis. Now, a Dimetrodon predated the dinosaurs. They went extinct 250 million years ago. And in the 1920s, a pathologist who A, clearly had way too much time on his hands, and B, clearly was not working in an RVU environment, decided to look at one of the shafts coming off the spine of this little fossil here. Noticed there was a healing callus, sectioned the callus, and diagnosed the Dimetrodon with osteomyelitis. And the fascinating thing is that the 250 million year old case of osteomyelitis really does highlight many of the modern challenges that we have in treating this disease. For example, the case went undiagnosed until rather late in the disease course when someone finally did a bone biopsy. The person who did the biopsy forgot to send it off for cultures to target our therapy. How often does that happen in the modern era? And of course, any treatment that was administered back in the day probably didn't work very well. Although I will point out, if there was treatment administered at the time, it was probably given orally because I don't think they had Dimetrodon opat at the time. But in between the time of the case of the Dimetrodon with osteomyelitis and today, very little changed in the management of this disease for over those 250 million years until this study was published in 1970. If you want to know why every physician in the United States, or I don't know, on the planet, or frankly in our solar system, because I've surveyed Neptune and they do it there too, gives 4 to 6 weeks of IV antibiotics to treat osteomyelitis, it is actually directly from this quote in this manuscript published in the New England Journal of Medicine in 1970. You can literally trace the references back to this quote, okay? Now, this actually creates a precedence because it's going to come up again in the talk. It turns out if you want to create a urban legend in medicine in which everyone believes with religious fervor, like they'll blow you up if you don't believe it, right? With no data, all you need to do is publish an opinion in the New England Journal of Medicine. So that's what Dr. Waldvogel and his colleagues did in 1970. This is in the discussion section of this paper. And they said, in our experience, if you want to successfully treat osteo, you have to give IV antibiotics for 4 to 6 weeks. The problem is that it is in the discussion section of a retrospective uncontrolled case series of patients treated in the 1950s and 1960s with IV penicillin and aminoglycosides. They didn't try any oral, they didn't try anything. They just gave IV penicillin and aminoglycosides, okay? So like when I show you like the randomized controlled trials and stuff, and you're like, those trials have flaws. This is what you're hitting me back with. Really? Seriously? Wow. Okay. Okay. So about a decade ago, Ben Lipsky and I were kind of frustrated with the state of the art of osteotherapy. So we did a systematic review. And one of the questions we asked was, can you deliver antibiotics into bone at levels adequate to inhibit microbial growth? And the answer is you can. For many types of antibiotics, there are dozens of studies in the literature asking this question. And the way these studies are all done is they administered antibiotics to patients who were either undergoing amputation or biopsy. And then they took the amputated or biopsied material, ground up the bone, and measured the antibiotic in the bone. And it turns out that fluoroquinolones, metronidazole, linezolid, Bactrim, Clinda, rifampin, there are others, fosfomycin, fusidic acid, there are others, all achieve levels in bone that are well in excess of the target MICs of relevant pathogens. So just pharmacologically, we can hypothesize that it should be possible to treat infections in bone orally because we can get antibiotics into bone at concentrations above the target MICs of relevant pathogens. Are there clinical data that validate this hypothesis? Yeah, there are a lot. There are now more than 40 published observational studies showing that oral therapy results in clinical outcomes at least as good as IV therapy for chronic osteomyelitis. And very importantly, after more than 15 years of searching this literature, I've never found a single observational study that showed contrary, that showed that IV resulted in better outcomes. So then you say, yeah, but those are observational studies. Don't you got it? There's all bias. Don't you got any randomized controlled trials you could show me? Yeah, I have 9 of them. Nine. What's like the magic? Are you like, well, 9? If you had 11, I believe you, but 9? Really? Like, when do you, are you just like piling on and it's starting to become embarrassing when you have like 9 randomized controlled trials all showing the same thing, that oral therapy is as effective as IV, but with reduced adverse events, with none, 0, showing that IV is superior. Like that scorecard is pretty impressive, actually. I don't have time to show all 9, so we'll just walk through the largest of them. When Oviva was published, people, oh, we finally have a randomized controlled trial. I don't know. I'm like, you mean you finally have the 8th randomized? Because it was the 8th. Now there's been one since. But yeah, let's talk about Oviva because it's larger than all the others and it makes the point. Multi-center randomized controlled trial, 1,000 patients, okay? 6 weeks of oral versus IV therapy. There was IV lead-in averaging about 10 days in the oral arm. Multiple sites of osteo, multiple organisms, and multiple different types of antibiotics used off a menu that was selected by the investigators. In every endpoint looked at, no matter what population was studied or what the endpoint was, oral therapy was at least as effective. And in fact, in the principal and prioritized secondary endpoints, not only was there no difference statistically, but the point estimate favored oral therapy for clinical cure. Now, so skeptical was the journal that published this paper that this was the journal that created the IV myth in the first place, of course, a half century earlier. It forced the authors after submission, during resubmission, to conduct a non-pre-planned post hoc worst case sensitivity analysis where they set all missing data in the oral arm to failure and all missing data in the IV arm to success. And even that worst case scenario failed to demonstrate that IV was superior. But you know what actually was different between IV and oral therapy? The rate of harm due to the catheter, which was 9-fold more common in the IV arm, not 9%, 9-fold more common in the IV than oral arm, about which my commentary is duh. And you know what else was different? The investigators administered patient satisfaction surveys to all randomized patients. And patients that have been randomized to oral therapy reported statistically significantly better mobility, self-care activity, pain, discomfort, anxiety, and depression. It turns out patients don't like having large plastic tubing in their central veins for 6 weeks on end, again, about which my comment is duh. And of course, oral therapy was less expensive. So a few years ago now, some colleagues got together to systematically review all this. Here is a tabular summary of your 9 randomized controlled trials with your treatment success rate oral versus IV, weighted average oral, weighted average IV. And if you prefer more formal statistics, here is your random effects forest plot meta-analysis, demonstrating unequivocally no difference in outcomes by clinical cure between oral and IV therapy for this disease, and your funnel plot showing no evidence of publication bias. Now, separate from these 9 randomized controlled trials, completely separate, there are 18 other studies, 17 of which are randomized controlled trials, one of which is a quasi-experimental pre-post study, 9 in adults and 9 in kids, in which both arms predominantly studied oral therapy for osteomyelitis. These studies were either comparing different oral regimens or different durations of therapy. And in all of these studies in both arms, the cure rates were in the same 75 to 85% rate that we've come to expect from osteomyelitis trials. These trials evaluated every conceivable manifestation of osteomyelitis, including vertebral, diabetic foot, prosthetic joint, with multiple different antimicrobial regimens. Even beta-lactams are in there for osteomyelitis. For diabetic foot, amoxiclav is the most common studied oral regimen in these trials, but you've also got quinolones, Clenda, linezolid, Bactrim, all these regimens studied. When you combine these 18 randomized controlled trials, or 18 studies, one of which is quasi-experimental, plus the other 9 trials I already showed you comparing oral to IV, it is an unbelievably massive amount of data demonstrated. This is not a scientific question anymore, okay? This is a question of tradition versus data. The data are in that oral therapy works for this disease. There is no scientific argument at this point. But what about bacteremia and endocarditis, which are different diseases? Well, I showed you the historical reason why people think you have to use IV therapy for osteo. If you ask that question for endocarditis, the answer begins with this case series published in 1943. Remember that before penicillin, sulfa drugs were really the first real antibacterial agents available to clinicians to use. They hit the market in the United States in late 1936. And they worked quite well for many types of infections, but endocarditis really wasn't one of them. And so it was kind of recognized that outcomes were disappointing for endocarditis. So this physician decided in 1943 to do a retrospective case series, a historically controlled case series, where he looked at 750 patients with endocarditis treated with sulfa drugs and compared them to 2,500 patients from the pre-sulfa era to see what the outcomes were. What he reported was that before sulfa, endocarditis was almost uniformly fatal. Its mortality rate was greater than 99%. There was less than 1% recovery rate. Now, sulfa did better than that. It got you to a 4% survival rate, which is better than less than 1%, but could sort of be mathematically summarized as 400% of a not very good outcome is 400% of a not very good outcome. Nobody was impressed by this. And there were multiple other case series that found similar results. So sulfa fell out of favor very quickly for endocarditis. In the late 40s and early 50s, when erythromycin and tetracycline came along, they were also attempted orally, and they did a little bit better. They got you to around a 20, maybe up to 30% treatment success rate. But it was nowhere near what was being seen with IV penicillin in the 75, 80, 85% cure rates. These were the data available. These case series with old antibiotics were the sum data available in 1954 when one of the true giants of infectious diseases, probably the most influential ID doctor of the 20th century, Max Finley, published a review article in the New England Journal of Medicine, in which he said, the oral route may sometimes work, but it probably usually doesn't, although we don't really know because there's not a lot of data. That's his quote. Here it is right here. This is a direct quote from the article. And if you want to know why everyone in the universe thinks you have to give IV therapy for endocarditis, you can trace from the guidelines and the references all the way back to this review article. And here's the quote. So again, when I show you the randomized controlled trials showing that oral therapy works, and you're like, those trials have flaws, this is what you're hitting me back with. So again, frustration, colleagues publish systematic review, okay? And ask the question, can you get antibiotics above the target MIC for organisms? Now, tetracycline and erythromycin have enormous volumes of distribution. These are not bloodstream drugs. They rapidly leave the bloodstream and are heavily concentrated intracellularly. Why would you think that drugs that achieve very low levels in blood would be effective to treat a high-grade bloodstream infection? Sulfa does a little better in blood, higher levels, but it is a dreadfully inactive antimicrobial. Now remember, this is not trim sulfa. This is sulfa by itself. And again, you cannot reliably get sulfa like tetracycline and erythromycin. You cannot get levels in blood that reliably exceed the target MICs. Why would you think it would work for endocarditis? Doesn't make any sense. In contrast, there are numerous modern oral antibiotics that clearly have levels in blood that are well in excess of the target MICs. So our question should be, do these drugs work? Not, do these drugs work? These drugs shouldn't work. I don't have time to walk through the numerous observational studies of oral therapy for bacteremia, all of which suggest that oral therapy works. Instead, we'll just cut to the chase. There are now 11 randomized controlled trials of oral therapy for bacteremia. Really? 11? Wow. 7 for gram-positive organisms, including Staph aureus, and 4 for gram-negative. And in all of these studies, oral therapy was at least non-inferior to IV therapy. In a couple of the studies, amazingly, oral therapy was statistically superior in outcome to IV therapy for bacteremia, and in none was IV therapy superior. Here are your 11 now studies published comparing oral to IV for bacteremia, telling you which drugs against which bugs. And of course, actually, I have to add the Sabato trial into this table. I guess I forgot to do that. That's Staph aureus, which was just recently published. And here is your weighted average, your oral success, IV success, and your weighted average of oral versus IV, showing again, oral looks better than IV. And here is your random effects meta-analysis forest plot. Now I can't quite conclude statistical superiority here because we're right at the 0 boundary, but it sure looks kind of better. And if you look at how the data trend, the one thing I can tell you very confidently is that oral therapy isn't worse. If anything, it looks better. It's definitely not worse for bacteremia across multiple organisms and multiple types of antibiotics. But that's bacteremia. That doesn't necessarily mean the same is going to be true for endocarditis. Do you have any data for endocarditis? We have 15 observational studies showing that oral therapy achieves outcomes of endocarditis similar to those historically experienced with IV. Very diverse observational studies, mostly left-sided, many different types of organisms, all of which showing oral therapy appears to work. There are also 4 slightly more rigorous retrospective studies, 4 case control or cohort studies. The first one was from France in 2011. 19 patients treated orally were compared to 47 patients treated IV only. Now, the important thing here is that the 19 patients treated orally They weren't switched to oral therapy because they were doing well. They switched to oral therapy because either they developed complications from the IV, or this was before daptomycin, they were infected with organisms resistant to IV therapy and they were put on oral linezolid. None of the 19 patients switched died. A quarter of those not switched died. Biased, observational, all that stuff, but certainly suggests that you can select patients who are eligible for oral therapy for this disease. A larger case control study a couple of years later, now we're talking 200 patients in each arm, mostly left-sided, lots of prosthetic devices and prosthetic valves, many different organisms, including staph, many different endomicrobials. Patients who were switched to oral therapy had statistically significantly less death. Statistically less death with oral therapy. Now, again, it's biased, it's retrospective, all that stuff. But again, it suggests that you can find patients that are safe to treat orally. Then there was our cohort study from our safety net system of 3 hospitals in LA, 46 patients treated orally over a two-ish year period. The majority of these were caused by staph. And in fact, in the oral arm, there was significantly more MRSA than there was in the IV arm. No difference in clinical outcome, even by multivariate analysis, but substantially more adverse events with IV therapy. Also, the amount of IV lead-in time made no difference. People who got longer IV did not do better. And then finally, this one just came out in the last few months. This is now a national study, observationally, in Denmark, showing what happened at a population level when they implement the results of a randomized controlled trial, which we'll get to in a few minutes, called POET. And in this large national observational study, patients who got oral therapy with endocarditis had statistically significant, so here's your composite outcome. It's not quite superior, but overall, oral certainly looks better by Kaplan-Meier. But if you just look at all-cause mortality, if you take out the other components and just look at all-cause mortality, oral therapy was statistically superior to IV therapy for endocarditis, the opposite of what you would have thought. So lots of observational data showing that oral therapy works and suggesting that it might actually be better than IV for endocarditis. What do the randomized control trials say? There are 3 randomized control trials and a quasi-experimental study. The first randomized control trial is 1991, all strep, Viridans arbobis, not that hard to treat. And so 30 patients were randomized, everybody was cured, no difference in IV oral therapy for this disease. The second randomized control trial was all staph, 100% Staph aureus. This is the Johns Hopkins studies in patients with a history of injection drug use, who presented to the ER with a fever and a suspicion of endocarditis. They had a murmur or some other reason why the ED physician felt there's a risk of endocarditis here. And one of the important things about this study is that the patients were randomized in the ED to oral therapy. They got no IV lead-in. They were randomized in the ED to oral versus IV. The oral regimen used was a weird regimen, which most of us today would say, I'm not going to use that. Cipro is not a drug most of us trust for staph anymore because the rate of emergence of resistance is so high with Cipro, but they combined it with rifampin to address that rate of emergence of resistance. There was no difference in clinical or microbiological cure in the study, but there was a massive difference in adverse events, 20-fold higher rate of adverse events in the IV arm than in the oral arm. Now, this study has limitations, like all studies do. It's not a huge study. It's mostly younger patients and mostly right-sided endocarditis because it was IV drug use associated. They used a weird oral regimen we've already gone through. In my mind, Cipro is not a good drug to use, and they used, in my mind, the wrong dose of rifampin. But that would have, sort of handicapped the oral arm, and it still did fine. And then there's the big complaint about this study. There were only 5 cases of MRSA in this trial, so I don't know what it means. Okay, guys, I'm so tired of hearing this, okay? This concern about, we don't have enough MRSA data, I don't know, is a phantom menace. I'm so tired of this complaint. Let's just get this out of the way so you don't have to ask me during the Q&A. Does anybody disagree with this statement. IV therapy with beta-lactams for MSSA is at least as effective as IV Vanco is for MRSA. Anybody disagree with that? Because I've given this talk like 80 times on 5 continents now. Haven't hit Antarctica yet, but I've given this talk like 80 times and no one's ever disagreed with this, okay? So if you agree with this statement, then what we have is the mathematical transitive principle. If A equals B and B equals C, then A equals C, okay? If IV beta-lactams are at least as effective in treating MSSA as IV Vanco is for treating MRSA, and I then show that oral therapy is at least as effective as the more effective IV therapy for MSSA, then it must be at least as effective as the IV therapy for MRSA. It's the mathematical transitive principle. Note, you couldn't go the other direction. If I showed that oral therapy was as effective as Vanco for MRSA, none of us, including me, would feel confident concluding that that also means it's as good as beta-lactams for MSSA. But that's not the direction of the data. This complaint, we don't have enough MRSA data, is the last vestige. It's the last desperate gasp of those who don't want to evolve their practice to come up with an excuse for why they shouldn't. It makes no sense whatsoever based on data. Now, before I get to the large POET study, there is one other study that is worth mentioning. This is a quasi-experimental pre-post study. So it's not randomized, but all patients were consecutively treated. So the way they did this is in 2012, in January of 2012, at this one hospital in France, they implemented a protocol to treat Staph aureus endocarditis. All of these patients had Staph aureus. Everybody got 1 week lead-in of IV therapy, and then after 1 week, they were switched to oral Bactrim for 5 more weeks. And they did that for 171 consecutive patients from 2012 to 2019, at which time they went back and looked at 170 consecutive control patients from the prior decade that had been treated intravenously and asked the question, were there differences in outcomes? All Staph aureus, mostly left-sided, lots of prosthetic valves and devices, and they did have MRSA. Amazingly, patients treated with the oral regimen had statistically significant reductions in relapse and in death. Okay, just as sort of the observational studies I showed you suggest, here's a quasi-experimental study, statistically lower death with oral therapy. Now, remember this magnitude of this difference, this 11% reduction in death, because it's going to come up again in a minute. That brings us to the POET study, the largest of the trials thus far done. 400 patients randomized, multi-center in Europe, mostly left-sided disease, lots of prosthetic valves and devices, many different regimens used. They're selected by the enrolling clinician off a menu. In the original manuscript, at 6 months of follow-up, there was no significant difference between oral and IV therapy for treating endocarditis. Numerically, oral looked kind of better, but it wasn't statistically different. Bottom line is oral worked. It was not worse than IV therapy, kind of trended in favor of, but not statistically significantly different than IV. These investigators have subsequently published 3.5-year and now 5-year follow-up data of the same patients. And by 3.5 years of follow-up, there were statistically lower treatment failures and statistically lower death than IV therapy in the oral arm. And notice the magnitude of the difference, 11%, the same magnitude as was described in the French quasi-experimental study. In the largest ever conducted randomized controlled trial, not only was oral not inferior to IV, it was superior on death, which is kind of a hard outcome when you stop and think about it. So for endocarditis, we have 20 observational studies, a quasi-experimental study, and 3 randomized controlled trials. all of which show oral therapy works. And in the largest of the observational, quasi-experimental, and randomized control trials, not only was oral not worse, it was better. And IV was not better in any of these studies. This is like not what you would have expected to find when you set out to systematically review this literature. Here is your summary table, oral versus IV. And again, the quasi-experimental study is shown in italics. Your weighted average without the quasi-experimental study or with, it doesn't actually change the results very much. It just increases the sample size. Here's your formal random effects meta-analysis forest plot. If you include the quasi-experimental study, you conclude statistical superiority of oral therapy. Now, you don't like the quasi-experimental study? Okay, cool. Let's take it out. No problem. You can't any longer conclude statistical superiority. The point estimate doesn't change, but the confidence interval widens out. So you're now crossing the zero line. But what you can very confidently conclude is that oral therapy ain't worse. All of the available controlled studies, 22 randomized controlled trials, show that oral therapy is safe and effective for these three diseases, and there is not a single published contrary controlled study. Now, before I wrap up and allow you to begin pelting me with fruits and vegetables or shooting death rays at me via photons through my computer screen, let's just quickly go through some of the common questions that I get asked. Are you like off your meds again? That's like people have like, okay, I admit it, I'm off my meds this morning, but I am on electrical therapy and they are cranking up the voltage. So like, I get that I'm nuts and stuff and I totally accept that, but this is like the least crazy thing that I've ever believed. So just believe me on this one. The voltage is working, trust me. Okay. Now, are you like saying any oral therapy can be used for these infections? No. I sure wouldn't use sulfanilamide to treat endocarditis, right? No, you want to use a bioavailable agent that has published efficacy data. Don't make something up, use something that's been published to work. And Lord knows there's a large selection to choose from at this point. Are you like really suggesting oral therapy is better than IV? I don't know. Okay, there certainly is a suggestion from the data for endocarditis that oral therapy might actually be superior. But I personally think we would want a second randomized controlled trial to confirm. Point is, it's not less effective. And remember, that was the question we started out with. Can you reasonably use oral therapy? It might be more effective than IV for endocarditis. I'm not sure. If it is, why would that be? That's such a crazy thought. What could possibly be the explanation? I've heard numerous hypotheses around this, don't know the answer, but I will say, if you look at the Kaplan-Meier curves, you might begin to derive a hint. In the original POET paper, so this is IV therapy and it's death, so higher is worse, and here is oral. The Kaplan-Meier mortality curves in the original paper began to diverge during the 42 days of therapy. So while being treated, those curves began to diverge, but the magnitude of the difference continued to widen out over months to years. At 1 year and 2 years, the curves are still diverging. At 3 years, they're diverging. For 5 years, those curves are still widening out. What could possibly cause someone to continue to have a higher risk of death 5 years after they stopped the treatment for the disease in question? I don't know for sure, but it sure makes you wonder if the real key here is harm avoidance. You didn't get the DVT from the line 5 years ago that was going to continue to require anticoagulation therapy or cause complications in your vasculature for years after. Maybe the key here is that it's better because it avoids death from harm caused by the IV. I think that this is a hypothesis that merits testing in future studies. And then there's this one, but guidelines. I can't give oral therapy because the guidelines say not to. All right, folks, I'm sorry to say this, but I am done with the guidelines. Don't care about no guidelines. Done with that. I've written them off completely. Guidelines are an ivory tower academic attempt to impose standards of care based on no data. It is shocking the number of recommendations made in guidelines because the writers said so, not because there are data to support it. And that's why we invented wiki guidelines, which there are now published for both osteo and endocarditis. Others are coming. The charter of wiki guidelines states you cannot make a recommendation unless there are reproducible, prospective, high quality data. In the absence of such data, what you do is describe choices, options, pros and cons, but you don't make a recommendation. There are now wiki guidelines for both osteo and endocarditis. And ironically, the large majority of questions asked, we could not make recommendations for because there was not high quality data. Ironically, one of the few things we could reliably state based on high quality reproducible data is that oral therapy works for both of these diseases. So if you do want to quote a guideline, you now have 2 published guidelines in a reputable journal telling you can use oral therapy for these diseases. Now, I argue about this a lot, as you might imagine. And so I've been sort of driven to distraction. It almost feels cartoonish to me at this point, the people insisting on IV therapy. So to those who insist that the data are flawed and that you have to use IV antibiotics, my response is IV antibiotics aren't more effective on a train. They aren't more effective on a plane. They aren't more effective on a bus. They aren't more effective when there's pus. I do not like IV antibiotics, by damn. I do not like them, Sam. That's right. I went full-blown Dr. Seuss on y'all. There's no good comeback to Dr. Seuss, people. When you go to the Dr. Seuss level, then you know you are at like the high level there. There's no real way to rebut that, right? So, all right, we're almost done. The torture has almost ended. We have written up expected practices for the doctors in our system to help them select which patients are eligible for oral therapy. And what we have put into our expected practice is that you can switch to oral therapy. There's no minimum duration of IV therapy because the data don't support one. They're all over the map. And we have an endocarditis trials where there was no IV lead-in. You can switch to oral therapy when all 5 of these conditions are true. The patient is clinically stable. Source control has been achieved if it's needed. It doesn't make any sense to put someone on oral therapy and then make them NPO for a procedure to drain pus. So if you need source control, do that first. We would like the bacteremia to be cleared or clearing. And the reason is the number one reason it doesn't clear is that you haven't done source control. We don't want people rushed home on oral therapy without source control having been done. You have a published regimen that has demonstrated efficacy against the target bacteria. The gut is working, and there are no socioeconomic reasons to prefer IV therapy. What does that mean? We have a lot of homeless patients, and as I'm sure you do as well, in some cases, if I could justify housing for someone, a SNF, for example, by giving them a skilled nursing need with the IV, holistically for that patient, IV may make more sense and be better for that patient. So we're suggesting, and there may be insurance reasons why you want IV as well. We're suggesting that the decision of oral and IV be part of an overall question of what is best holistically for this patient. And you can switch to oral therapy whenever all 5 of these criteria are met. If that's on day 14, do it on day 14. If it's on day 1, do it on day 1. I'm going to close with this quote. This is the last slide. 120 some odd years ago, Dr. Osler did a tour of rural America to see how doctors were practicing medicine. And what he saw kind of horrified him. He then wrote an article, which he then gave as a graduating address, which was published in the British Medical Journal. He was kind of horrified by doctors' tendencies to give treatments that had never been studied. And when he asked them why, they were like, well, everybody knows this is how you do it. He wrote that conservatism and old fogeyism are totally different things. The motto of conservatism is prove all things and hold fast that which is good. The motto of old fogeyism, prove nothing and hold fast that which is old. I really think he would be sad that in 2024, we are still not great in the medical community at evolving our practice based on new evidence. Let's try to do better. With that, please, you may begin alighting the effigies and burning them, and you may begin firing death rays at me through the computer screen. Thank you very much.
Thank you so much, Brad. That was just an excellent talk. I really enjoyed it. I think one of the things that really struck me that you brought out was this idea that in the absence of perfect data, you have to continue historical practice. And for me, in my little world of hospital epidemiology, I would argue it's the same thing with doing contact precautions for MRSA and VRE. We never had good data to support that practice, but yet and that we must have randomized controlled clinical trials to stop it. And there's an interesting book that came out a couple years ago called Subtract by this guy named Leidy Klotz. And the whole idea of the book is that, humans just have difficulty taking things away. Like there's a real tendency for us to add interventions or add medications, but taking them away is much more difficult. I guess one question I have that I don't think you directly touched on here is, as we learned how to treat endocarditis and some other infections, we were told, as you mentioned, that therapy always has to be IV. But we were also taught that it had to be cidal. What do you think about that?
Well, I think you know what I think about that. What I think is that I'm going to tell you what I think, and then I'll tell you why. I think that everyone in the audience should identify the neuron in their cerebrum that stores the memory of the words cidal and static, and delete that neuron, whether it's via XRT or any other mechanism is fine. Okay, it is a useless concept that has no meaning, and data show that it's meaningless. So we actually systematically reviewed that as well, I think, as you know, Mike. When you look at randomized controlled trials that have compared static to cidal therapy for infections, all of them have shown no difference, except a couple showed a static agent was better. The only exception, we reviewed 56 such trials. The only exception was that tigecycline was inferior to imipenem for VAP. But the problem with tigecycline wasn't that it was static, it was the wrong dose was used. So static and cidal is a useless concept that has no meaning. And in fact, a lot of the superiority for bacteremia and endocarditis may be driven by linezolid, which is a static agent, but a wonderfully effective static agent.
There is a question in the comments in the chat section. And the question surrounds, what about immunocompromised patients? Do you think differently about them?
I guess the way I would start answering that is, do you think that bacteria in immunocompromised patients know that they shouldn't stop growing because the patient's immunocompromised? Again, think about this sort of like, if you sort of think about, you have antibiotics, they're getting to a site of infection where they're killing the bacteria. The bacteria don't know, oh, this patient has leukemia, I'm gonna not stop growing because right? There is no evidence that you need IV therapy in immunocompromised patients. And again, the starting point of that question presumes that IV is more powerful, right? That's why you're like, do I need a more powerful agent if the immune system isn't working, right? But that presumes that IV is more powerful, and it isn't, okay? For some drugs where you just can't get good levels, yeah, you got to give the damn drug IV. If the gut isn't working, you got to give the drug IV. But if you get antibiotics to where the bacteria is at adequate levels, it doesn't make any difference. And IV is not more powerful. We got to get past that.
We still have a minute or so. Does anybody else have a question that they would like to ask Dr. Spellberg? You could either put it in the chat or unmute yourself and ask the question.
It's a great talk. I have a simple question, like when you say that, okay, oral therapy is better than the IV. So in oral therapy, what happens to the gut microbiome? Whether that will affect the gut microbiome? How does it, in that case, okay, how oral is better than the IV?
That's a good question, and it comes up periodically. There have been limited data on this. It's not been well studied. There are a couple of studies that have looked at the effect on the microbiome of oral or IV agents. And actually, it turns out not much of a difference. Remember, these drugs are all metabolized, and their metabolites have the same sort of effect on microbiomes as the starting point. So there's no good evidence that oral agents cause more harm to the microbiome than IV agents do. In fact, what limited available data there are suggests that there isn't much difference between the two.
So in that case, probably with IV, the endothelium is playing a major role.
I mean, the way I envision it, the way I think about it is that the IV drug is metabolized, and those metabolites end up going through biliary clearance into the gut and having antimicrobial effects in the gut.
So one more question. What about in sepsis patients? Is it oral is better than the IV in sepsis?
Yeah. Well, I think if you're talking about shock specifically, yeah, I mean, I think the problem is all of us would say, and I would say the same thing, I don't know that I trust absorption in someone who's not achieving good blood flow to the gut. Somebody who is really sick and unstable, that's why the first parameter of our can they get oral therapy is, are they clinically stable? If they are not clinically stable, your concern is, my concern is, all of our concern is, can you really absorb? And so I think that I think that if blood flow to the gut is in question, I wouldn't trust that I'm going to achieve the levels that were published in those studies at the site of infection. So I think in an unstable patient, IV definitely, all of us would say yes, give IV to that patient.
All right, Brad, thanks so much. Excellent talk. Really enjoyed it. Have a good day.
Thank you, Mike. It's great to see you. Thanks for the invitation.